Have you had more than one miscarriage and thinking that IVF might be the right next step for you? You are in the right place. Many people are offered IVF with genetic screening of embryos as a way to decrease the risk of another miscarriage. But there are many pros and cons, and that is what I'm going to teach you all about today. I'm Dr. Lora Shahine, a double board certified OBGYN and reproductive endocrinologist, fertility expert who's been helping people build families with miscarriages and treatments like IVF for over 20 years. And this is a common dilemma that I am discussing with my patients. They have recurrent miscarriages and they're thinking about IVF as a way to decrease their risk of miscarriage in another pregnancy. And this is not just a black and white, easy decision to make. There's lots of pros and cons. I'm going to help walk you through it today. I'm so glad that you found this channel, this video. If this is your first time finding my channel, be sure and subscribe to get my weekly videos all about reproductive health, miscarriage, IVF, lifestyle optimization. And if you are coming back to the channel because you found a previous video valuable, welcome back. I am so happy that you're here to learn. There are two other ways to learn and get resources and education from me. Number one is my weekly Brave and Curious podcast. You can listen anywhere you listen to podcasts. And the second is signing up for my newsletter, the link in the description below, where you can get updates on fertility in the news, recommendations that I have, and just common reflections. But today we are going to talk all about the option of IVF to treat recurrent miscarriage. And this is a common issue that I'm talking about with my patients every single day. And I want you to understand the pros and cons, and in the end, have a lot of information so that you can go back to your doctor and your provider and really figure out what the right next step is for you. So the topics that we're going to cover today are as follows. Number one, why would you do IVF for people that are already getting pregnant? Why is IVF considered a treatment for recurrent miscarriage? Topic number two, why not do IVF to decrease the risk of miscarriage? Once you hear and how I explain why people think about this as an option, you might say, well, why wouldn't everybody do this? Topic number three, real life counseling. I'm going to give you some patient examples and walk you through common conversations that I would have with these patients in different scenarios. Topic number four, we'll go through true pros and cons of doing IVF for recurrent miscarriage. Topic number five, some key considerations that I talk to my patients about as they're considering this option. And finally, topic number six, some final thoughts for me and some resources to help you learn more. Topic number one, why IVF for recurrent miscarriage? Oftentimes patients say, I'm not having any trouble getting pregnant. I'm having trouble keeping the pregnancy. And there's this assumption that there must be something wrong with the person who's getting pregnant, and we've got to fix that issue because obviously there's got to be nothing wrong with the pregnancy or no fertility issues because they're getting pregnant. And IVF is thought as a fertility treatment or only for people who are not getting pregnant. Well, this is where this comes in. The most common cause of first trimester miscarriage is a chromosome imbalance in the embryo. In cases where you can test pregnancy tissue after a miscarriage, 60 to 80% of the time, you will find that pregnancy tissue shows that when the egg and sperm came together and each gave half of the genetic content in the form of those little chromosomes, those stacks of genes that carry the genetic code, if there's an imbalance of these chromosomes so that there's an extra number 7 or missing a number 11 chromosome, there's 23 pairs of chromosomes, and if there's an imbalance or missing big portions, etc., then all of the steps can go right as far as egg and sperm finding each other, fertilization happening, cells dividing, the embryo implanting. But at some point in the pregnancy, and it's usually within the first trimester, the pregnancy will stop developing, the body will get the message, and people will have a miscarriage. Now, a lot of people do not get this testing on their miscarriage. Either it happens too soon, or it isn't discussed with them, or they do talk to their doctor about it, but they decide not to do it, and they don't have this information. So you can't assume that miscarriages are from a chromosome imbalance, but it is just important to realize that it is so common for the reason people are having miscarriages to be an issue within the embryo. So again, how do you have this link between IVF and miscarriage? Well, in IVF, you've got the embryos outside of the body. You stimulate the ovaries in the woman, and while she's totally asleep and comfortable, you extract the eggs in a simple procedure called an egg retrieval. You've got the eggs in the lab, you get a sperm sample, you help the eggs and sperm fertilize and watch the embryos grow in the lab over about a week. And when the embryos are fully formed, they're blastocysts, they're about 100 to 200 cells. You have an option at this time of biopsying about 5 to 10 cells away from the embryo, freezing the embryo, and shipping these cells to a specialty lab to test for chromosome balance. So there's an option when anybody is creating embryos and doing IVF, they'll talk to their doctor about whether or not to do PGT-A testing or pre-implantation genetic testing for aneuploidy. As soon as this technology and this technique was available to patients and doctors alike, people were thinking, well, who would benefit from using this technology? And so you just kind of put the puzzle pieces together. The most common cause of miscarriage is a chromosome imbalance in the embryo. We now have an ability to test embryos for chromosome imbalance before somebody gets pregnant. Why not use IVF with PGT-A, or testing of the chromosomes, as a treatment for recurrent miscarriage? That is where this link comes together. And early studies really did show that using this technology might decrease the risk of another miscarriage. One study I want to share with you is by Munay et al. It was published in Fertility and Sterility Journal in 2005. It was titled Pre-Implantation Genetic Diagnosis Reduces Pregnancy Loss in Women Aged 35 years and older with a history of recurrent miscarriage. And what they did in the study is they looked at people who had had 3 or more miscarriages. They'd had an evaluation for recurrent miscarriage, including anatomy testing, hormone testing, etc. And they were unexplained. There was nothing that they could diagnose in the people that were getting pregnant. And so the assumption is it was something going on with the embryos, like a chromosome imbalance. And they were offered IVF with PGT-A testing. And they saw that in the patients that had a transfer of a euploid embryo or a chromosome balanced embryo, they had a lower miscarriage rate than what they would have expected for their age. So for example, if someone who's 35 years or older, the chance of miscarriage without this genetic testing is about 44%. So positive pregnancy test, 44% risk of miscarriage after that. But in the patients that had an embryo transfer with a normal embryo or a euploid embryo, their miscarriage rate was about 12%. So the authors were saying in these couples that were having recurrent miscarriages for no other reason, if they did IVF with PGT-A testing, they had a lower chance of miscarriage in their next pregnancy. This is something that we should offer patients. And so people adopted that pretty quickly. Now, this is an old study. It's 20 years old. They were actually doing testing a little bit differently back in that day and age. Technology has changed so much. And an issue I have with this particular study is that they're only including patients that actually had a euploid embryo to transfer. And so when you're counseling a patient that, hey, your miscarriage rate is going to go from 44% down to 12% with this intervention, you have to really understand that there are some people that go into an IVF cycle and they don't make it to egg retrieval because they have poor response, or they don't have any embryos that make it to blastocyst to test, or all of the embryos are abnormal. So early studies like this were very exciting, but you always have to look at the data very, very closely and say, just because theoretically this was really exciting, is this really going to help my patients in the real world? So topic number 2 sounds great. IVF will screen for embryos without chromosome imbalance. This is going to help people have lower miscarriages. Everyone should do it, right? Well, not so fast. So again, you have to look at the studies and kind of pick them apart and realize, what are they showing? What are they not showing? Some studies since then haven't shown a significant benefit, or it really depends on the patients that they're including in the treatment arm about whether or not this is really helping people with recurrent miscarriage. So not so fast. Not everyone who's having recurrent miscarriages needs to do IVF with PGT-A as a treatment option, but it is something that's interesting and something that should be discussed. I just want to point out, this is something that's really hard to study because the intervention that is IVF with biopsying embryos and transferring embryos without chromosome issues, that is a significant cost to the patients, the clinics, the insurance companies if someone has coverage. And if you're trying to figure out if an intervention is really helping a problem when it comes to a medical issue, like does IVF with PGT-A really truly help somebody who is getting pregnant but just having recurrent miscarriage, the best way to study that is to do a randomized controlled trial. Meaning you find people with recurrent miscarriages and you randomize them. Some people try their next pregnancy with IVF and chromosomal screening, and the other group doesn't. They just try to get pregnant again and then compare outcomes. Well, these are people's lives. These are people's families. IVF is not usually paid for in all circumstances with insurance or not. There's multiple factors that go into deciding this. And so it's really hard to make a clear study to answer this question. But right now, what we have are some studies showing decreased risks, other people saying, hey, there's pros and cons. And so I don't have a perfect randomized controlled trial to tell you that for your particular situation, doing IVF with PGT-A is going to absolutely be the best way to go for you. But I can talk you through the theory behind it, why people do get excited about it, the pros, the cons, and that's what the rest of the video is about. So topic number 3, real world counseling. This is what I do every day. I see a lot of patients with recurrent miscarriage, and I take a history. I do a recurrent pregnancy loss evaluation for them, looking at anatomy, hormones, genetics in the parents, immune issues, blood clotting issues, etc. And before I even do the testing, I say, listen, the most common cause of miscarriage is something within the embryo, and we're testing you as the people that are getting pregnant. So I'm going to try to find something that I can control, like a uterine septum, like a thyroid issue. But more than likely, we're going to come back at our follow-up visit, and I'm going to say, listen, all the testing is normal, and here are the options. Of course, if I find an issue, we're going to focus on it. But I'm talking about you come back, you get this diagnosis of unexplained recurrent miscarriage because we couldn't find an issue with the people that are getting pregnant. And now here are your options moving forward. And one option is to try again. Like people who are getting pregnant, the very next time that they get pregnant, it could be the perfect egg and the perfect sperm. All of the chromosomes, all the stars align, and they have a beautiful baby. But another option is to take more action and do IVF, create embryos, test these embryos for chromosome balance, and the very next time that they try to get pregnant, they've eliminated one of the variables that can be associated with miscarriage. And that is a really extreme thing to offer a patient. Like, look, we did the testing. There's nothing clear-cut that I can treat. Your options are to try again. I call that expectant management, maybe with some early support and some empiric interventions, but really trying again without IVF versus IVF, which takes time, cost, medication, and is drastically more intervention than trying without assistance. And this is a full discussion, and there is no single path for either of my patients, but I would love to talk you through what I do every single day. I thought it might be helpful to give you a scenario of 2 common types of patients that I will see. The first patient is named Olivia, and she is 32 years old. She's had 3 first trimester miscarriages, and her most recent pregnancy loss was tested, and it was aneuploid. So she was able to collect the tissue, or maybe she had a DNC. That tissue was sent to a lab, and it came back and said, hey, there were 3 copies of this particular chromosome in that pregnancy. That is why you had this miscarriage. And she knows that for sure. Not in the previous 2 pregnancies, but her most recent miscarriage. Her family goal is to have 2 children. So again, Olivia is 32 years old, 3 first trimester miscarriages. One of them was proven to be from abnormal chromosomes, and she would like to have 2 children. Mia is 39 years old. She's had 2 early miscarriages, so unable to be tested, so she doesn't know if it was from aneuploidy or not. And her family goal is also 2 children. So these are 2 common scenarios, Olivia and Mia. So the first step for both of these patients is testing. So even though Mia has only had 2 miscarriages and they're pretty early along, I'm still going to offer her a full recurrent miscarriage evaluation. In 2013, the American Society of Reproductive Medicine updated the definition of infertility and recurrent miscarriage to include 2 miscarriages to allow for evaluation of recurrent miscarriage. So more than 1 miscarriage, you can ask for testing. I have a lot of information about this and kind of the history of testing, because so many people are told you can't do testing unless you've had 3 or more miscarriages. In my book is called Not Broken, An Approachable Guide to Miscarriage and Recurrent Pregnancy Loss. My whole first chapter is the definition of miscarriage, recurrent miscarriage, and how that definition is changed over time. So again, first thing is to test both Olivia and Mia, and then they're coming back for discussion, and I will tell you, no test came back abnormal for either Mia or Olivia or their partners. So they both have unexplained recurrent miscarriage. So topic number 4, pros and cons of IVF and how I break it down for these patients and all of my patients. So there's 6 things that I think about as far as pros and cons when it comes to IVF versus expectant management for recurrent miscarriage. So issue number 1 I talk to my patients about is risk of miscarriage in your subsequent pregnancy. So a pro of considering IVF is, will it decrease the risk of another miscarriage? And it really depends on the patient, their age, their fertility history, etc. So for example, Olivia is 32 years old and she's had 3 first trimester miscarriages. The very next time that she gets pregnant without intervention, her chance of another miscarriage is about 30 or 35%. If she were to go through IVF with chromosomal screening of her embryos, get a euploid or normal embryo, and transfer that euploid embryo, her chance of a miscarriage with that intervention is about 10%. So for her and her partner, the delta between risk is going from about a 30 to 35% chance of miscarriage with expectant management versus 10% risk of miscarriage with IVF if she gets a euploid embryo. Now, it's a little bit different for Olivia because Olivia is 39 years old. As eggs age, fewer and fewer of them are able to do all of the genetic work that they need to in order to fertilize with half of the genetic components from sperm and align those chromosomes. So statistically, more of Mia's eggs at age 39 are going to have difficulty with this chromosome balance. And that's one of the biggest reasons that people, as they age and get closer and past 40, have a higher miscarriage rate. So for Mia at 39 with 2 early miscarriages, the chances that she was to have a miscarriage in her next pregnancy with expectant management is really around 45 or 50%. And if she were to do IVF with PGT-A, have a euploid embryo and transfer it, her miscarriage rate is going to be about 10%. So the delta for Mia is much bigger. So for her, she would go from a 50% miscarriage rate to a 10% miscarriage rate. And this doesn't mean that she should absolutely move forward with IVF as her next step or treatment, but this is a point of discussion and important to review with patients as they're trying to weigh the pros and cons. The cons, though, are both of those patients still could have a miscarriage, even if they go through all of the work of doing the egg extraction, the cost of creating embryos, waiting for the test to come back. The miscarriage rate in an embryo transfer, even if that embryo has been tested, is not 0. And on average, it's about 10%. The second issue to think about with pros and cons with IVF or not for recurrent miscarriage is efficiency or time saving. So something that I ask my patients is, how long is it taking you to actually conceive and get pregnant? So for some people, they conceive within 1 or 2 cycles of trying. And they're just so exhausted because they keep having miscarriages. For other people, they say, yeah, I've had 2 or 3 miscarriages, but it's been over 2 or 3 years. And I think to myself, well, there might also be another underlying fertility piece in this. Not just each time that they've gotten pregnant, they've had a miscarriage, but it's also taking them a long time to get pregnant. So one of the benefits or pros of IVF is it can assess and treat other fertility issues, and there's a chance that someone might actually get pregnant sooner if they're going through IVF and doing this egg extraction, creating embryos, and genetic testing. So that is kind of pros and cons, but the con might be if someone conceives within 1 or 2 cycles of trying, doing IVF, which might actually take 2, 3, 6 months, depending on personal situation, funding, clinic schedule, all that kind of stuff. For that person, it actually might be faster to just try again because they conceive so easily. So as a second issue, something to talk about, something to think about your personal situation is how long is it actually taking you to get pregnant? The third issue to think about is just the emotional toll of miscarriage, your mental health. For some people, they've just really lost faith in their body. That's why the name of my book is Not Broken. You feel broken. A lot of my patients feel broken after miscarriage, like their body must be broken. And I'm trying to explain to people that miscarriage is not their fault. Their body is not broken. Most of the time, it's an embryo issue. But sometimes people they're terrified to even think about expectant management or trying again without assistance. And they love the idea of taking back control with IVF and testing the embryos, like having that reassurance that they've done something to decrease the risk of miscarriage. They've eliminated a variable that they can control. I just wish that IVF were free, easy, and 100% successful. But I will say an issue that people think about is just this emotional toll and just kind of an option to sort of say, I feel like I might be taking back more control if I do IVF. A fourth issue to think about is fertility preservation and kind of family goals and age that you are seeing the fertility specialist or starting your family. So IVF not only could decrease risk of miscarriage in the subsequent pregnancy, but if you do go through IVF and you have multiple embryos frozen, those embryos can be frozen for years to come and can help you add to your family in the future if you want to have more children in the future. So for Olivia, who's 32 years old, she wants to have 2 kids, but even if she were to try expectant management and got pregnant and had a beautiful baby, she'd deliver at 33, she might have more fertile years ahead of her. She might be sort of less drawn to using IVF as a next step for her family building. But Mia, who's 39 and she hasn't had any children yet, she really wants to have 2 kids. She's only had 2 miscarriages compared to Olivia's 3. But again, Mia is 39. And so if she got pregnant at 39, she would probably deliver at 40 and likely not be trying for baby number 2 until she's about 41. And fertility can change drastically in your late 30s, early 40s. And so Mia might be more drawn to the idea of IVF now, not only as a way to decrease the risk of a miscarriage in her next pregnancy, but also having embryos saved for future baby number 2. So this isn't an issue. It's something to think about and to take into consideration your family building goals when you're talking to your doctor about whether or not IVF is right to treat your recurrent miscarriage. So the fifth thing to think about is cost, or the financial burden of doing IVF compared to expectant management. If it's not 100% guaranteed, and this is tens of thousands of dollars out of pocket and lots of other things to take into account, it's really important to think about that. That's kind of like the elephant in the room. For my patients that are so fortunate to have fertility benefits and IVF coverage, it's usually an easier step to make because that financial burden is lifted. So really understanding the financial pros and cons, the investment that it is, not even just financial, but time and the medical piece of it. There's lots of pros and cons to think about IVF for recurrent miscarriage, but financial cost is something that's really important to take into consideration. And finally, the sixth thing that I talk to my patients about is ethics. Some people are really ethically challenged to think about having embryos in a lab that are frozen, or they only want one more child and they really don't want to have embryos frozen that they don't know what to do with later. There are options for embryos that are cryopreserved and your family is complete. And I talk to my patients about those options. But there are a lot of people that will not move forward with IVF for ethical reasons. And so it's really important to understand that up front and talk to your doctor about that as you're thinking about the pros and cons of IVF for recurrent miscarriage. So topic number 5, key considerations. I really went through this as I was giving you kind of these scenarios and kind of talking about how I talk to my patients. But there are 5 key things to consider. Number 1, family goals and age. So if your family goal is to have 2 or 3 children, you're in the second part of your 30s or getting closer or past 40, IVF might be very appealing, not only as a way to decrease the risk of miscarriage in your next pregnancy, but also freezing embryos to save for future children, if that's something that's right for you. And on the flip side, if you really only want to have one more child and you're conceiving easily, and the very next time that you get pregnant, you still have the chance of having a beautiful baby, you might be less inclined to choose IVF as your next step. Key consideration number 2 is fertility issues. So if you are conceiving easily within 1 or 2 or even 3 cycles, that is pretty fast, and you're going to know pretty soon if your next positive pregnancy test is going to result in a beautiful baby. Whereas if you're taking over 6 months to conceive, there might be a fertility piece of the puzzle, and it is really important as a part of your recurrent miscarriage evaluation to also do fertility testing as well. You just don't want to miss anything. But people that are taking a long time to conceive sometimes will move to IVF sooner because it is also addressing a lot of fertility issues as well. So key consideration number 3, your emotional wellness, your mental health. It's so important to take care of this no matter where you are in the journey. If my patients stop trying because it's just too hard and emotionally challenging, that's okay if they change their mind and they are excited to live a child-free life. But if they're pivoting because they don't have that mental health support, then I worry that's on me. And so I have a long list of mental health support options for patients. And I'm going to give that also in the resources at the end of this video. But it is common to want to take back control and to use IVF as a way to control a variable to decrease the risk of another miscarriage. But just that isn't the only answer to the emotional toll that this takes, because IVF is not 100%. So it is part of the equation. It is something that my patients talk to me about. But just using IVF as the treatment and not paying attention to the emotional piece and mental health wellness, that's leaving a big hole. So you got to do both at the same time, no matter whether or not you choose IVF. Key consideration number 4, ethics. You've got to talk to your doctor about if there are excess embryos that are frozen with IVF, what you feel comfortable doing with those embryos. And if that is ethically challenging for you, then maybe IVF is not the right next step. And key consideration number 5, of course, access to care, cost, and insurance coverage. All of these things are really important to ask key questions, get transparent numbers on the cost of any intervention that you choose. So topic number 6, our patient examples. Let's get back to Olivia and Mia, and let me tell you what I would offer them. So Olivia, remember, she is 32 years old, 3 first trimester miscarriages. Her most recent one was from a chromosome imbalance. It tested for aneuploidy, and she wants to have 2 kids. So I would offer her both expectant management and IVF. I would offer expectant management, even though one of her miscarriages was definitely chromosome. The very next time she gets pregnant, it's a brand new egg and a brand new embryo and an opportunity that that embryo would be normal. So IVF would have most likely prevented the miscarriage that she had from that aneuploid embryo, her 3rd miscarriage. But there can be miscarriages for other reasons as well. So it's not 100%. I think she is young. She's 32. I would hope that she would have a lot of fertile years ahead of her. If she conceives pretty quickly, I think it's very reasonable for her to try expectant management. And I would imagine that it's pretty common for that type of patient to maybe try one more time. And if they have another miscarriage, then pivot to IVF. But I've absolutely had people that are very similar to Olivia choose IVF as their very next step. What about Mia? Mia, remember, 39 years old, 2 early miscarriages, not tested, so we're not 100% sure they're from aneuploidy or not. And she really wants to have 2 children. So I would offer for Mia both expectant management and IVF. But I think for her scenario, because she's 39, because she has a higher risk of miscarriage with expectant management just based on age of her eggs, and she wants to have 2 children, and when she's trying to have baby number 2, she's going to be 41 or older, I would really kind of explain to her the benefits of IVF as a form of fertility preservation, and not her only option, but I would just think about the big picture of what her family goals are, her current age, and I think she would be much more likely to choose IVF as a next step compared to Olivia. But here's the truth. Both paths are valid and available for both patients. And I would never try to tell a patient what to do. I want to explain the options and the pros and cons of each, and then gather pieces of the puzzle to help me guide the conversation and answer the patient's questions. But at the end of the day, both of those patients could say, I want to do IVF tomorrow, and we could go right into it. Or both of those patients could say, I really want to try again on my own, and I would support them 100% in that decision. So in conclusion, I really want to end with a very hopeful message. I really do believe that people who are having miscarriages can go on to have their family without IVF. Think about all the things that are going right. Eggs are ovulating. Eggs and sperm found each other. Fertilization happened. Embryos were dividing. Cells were working. The uterus accepted the embryo, and cells were dividing. Implantation happened and continued. And so every pregnancy is a new opportunity. Brand new egg, brand new sperm, brand new opportunity for those chromosomes to line up. So I think that IVF is an option. I think it could be an efficiency model. I think it could decrease the risk of miscarriage in certain circumstances if you did the chromosomal screening. I think that it can be used as a fertility preservation tool. I don't want anyone to think it's the only option or treatment available for patients with unexplained recurrent miscarriage. I think it is an option, and everyone should have a thorough discussion with their doctor about their personal situation to find the right path for them. If you want to learn more about miscarriages, IVF, this option, I have a whole playlist on my YouTube channel about IVF, steps, how long it takes, what this PGT-A testing is. I have a whole playlist on early pregnancy and miscarriage that talks a lot about the testing that I would do. So just here on YouTube, lots of resources about these topics. And I wrote my book, Not Broken, An Approachable Guide to Miscarriage and Recurrent Pregnancy Loss, with information on definitions, testing, controversies in care, IVF as a treatment option, but not requirement. I also have resources on my Brave and Curious podcast. I've interviewed the very first miscarriage doula, Arden Carnett, to talk about that role and how that can support some people. I talked to the founder of the Recurrent Pregnancy Loss Association, Megan Hansen, to talk about the research that she's funding and the support that she provides. I have many interviews with people who support people with miscarriages in this community, so you can find that emotional support, that mental health support. And I truly hope that those resources are valuable. My book, my podcast, and all the information and resources here on my YouTube channel. I hope you found this valuable. Please share this with a friend who's considering doing IVF as an option for their recurrent miscarriage. And until next week, wishing you love, luck, and pineapples.